I want to take a few minutes to review some fundamentals of intubating patients. And this is not intended to be a deep dive or an exhaustive review of all the ins and outs of securing an airway, but rather it's meant to be a 4 or 5 minute review of how do we intubate your normal, healthy, average looking airways. What kind of tools do we use? What kind of communication are we looking for? What are some anatomic structures we want to be able to identify to communicate to the airway team? What's being seen. So let me start out by showing how we grade airways. After you do a laryngoscopy, you can see a variety of different views. It depends on the technique, and it obviously depends on the airway. But the final view that you see, we try to classify on this scale from 1 to 4. And 1 there you see on the left is a wide open airway where you can easily see the vocal cords. From top to bottom, you can see the epiglottis. I mean, this is about as normal as it gets. Over on the extreme, a grade 4 airway, all you really see is the base of the tongue. You don't see any arytenoids. You certainly don't see any vocal cords. Really, it's a terrible view because you can't tell where the esophagus is and where the vocal cords are. In between there, you have a grade 2 and a grade 3. The grade 2 airway, you can still see some of the vocal cords, but not all of the vocal cords. There are some classifications that will actually further divide grade 2 into 2A and 2B. But for this purposes, if you can see all of the vocal cords, it's a grade 1. If you can only see some of the vocal cords, it's a grade 2. Grade 3 is you only see the arytenoids. And here you'll see the arytenoids just below this epiglottis. This is the epiglottis. Just below that is the arytenoids. And then just above the epiglottis is the vallecula. And above that, of course, is the base of the tongue. So this is the different views that you might see. So when you're asked what kind of view did you have, you'll just say it was a grade 1 or is a grade 2, only so some of the vocal cords. Obviously, depending on your technique, you might be able to tweak things a little bit and turn a grade 2 view into a grade 1, or change a grade 4 into a grade 2. So sometimes it's the provider dependent. Sometimes it's just the airway, and you'll never get anything better than a grade 4 view. So let's look at the tools that we use. Here are the 2 fundamental blades that we use, right? The 2 basic blades is the Mac and the Miller. There are other types of blades, and again, this is not intended to be an exhaustive review of the pros and cons of each, but suffice it to say we use 2 different types. We have a Mac blade, which is curved, and we have the Miller blade, which is straight. Different people have preferences over these. Traditionally, the Mac blade is intended to be inserted such that the tip is just in the vallecula, so just above the epiglottis, whereas the Miller blade, the tip is intended to lift up on the epiglottis to theoretically give you a better view of those cords. In the videos I'm going to show you, we'll look at the, quote, traditional way of using a Mac, but then we're also going to see a video where the Mac blade is used to lift the epiglottis, and we're going to look at a view where the Miller blade is put in the vallecula, and you can see the epiglottis. So there's nothing in stone about how these are to be used. But it's good to know that at least the names, the Mac and the Miller, the Mac is the curved, the Miller is the straight blade. Let's look at some videos. So we're going to look at a total of 4 different laryngoscopy views. This first one, we're going to take our time, pause periodically through that to highlight some of the anatomic structures. And the subsequent 3 will be a little bit faster, just to review what we kind of learned in this video. So here in our first laryngoscopy video, we can obviously see the patient has already been put to sleep. The CRNA has already put in this case, it's a Mac blade into the airway, and they're holding the airway open with a finger there. And I'm just going to go down the airway with a fiber optic scope so that we can see some of these anatomic structures and make some points. The first thing you see here is be careful on the teeth. Here it's obviously touching, but there's no force being generated on that tooth. You just want to be careful not to create leverage. You really want, ideally, space to be in between that laryngoscopy, the laryngoscope, and any teeth. You also should see up here in the upper right hand, you really don't want to see the tongue hanging down there. You're going to see how this obstructs your view and can make difficult airways impossible, and it makes easy airways more difficult. So good technique all the time is what you would prefer, and that includes going all the way down the right gutter of the patient's mouth and then sweeping the tongue all the way to the left so you don't see any tongue hanging out there. As we proceed down into you can see right here, you can see how that tongue really obstructs your view. Behind the tongue, there's a great view. So In this case, it's okay because they had a grade 1 airway to begin with, so it's not an issue. But again, just better technique is to make sure that tongue is completely out of the way. Here you see the vocal cords hiding behind there. As you get behind the tongue, you're going to see 2 tonsillar beds. This particular child obviously has got very small tonsils, which is excellent. You can see there's a uvula here at the bottom of the screen. And as you go a bit further in, you can obviously see the vocal cords up there. You can see that this is a MAC blade being correctly used and being put in the vallecula, so that area just above the epiglottis. The epiglottis there is a bit whited out, but you can easily see it. And then you can see, obviously you don't get in this close typically, but you can see a very straight on view of what would be called a grade 1 airway, where you easily see the epiglottis, you see the full cords, you see the arytenoids just beneath the cords. It's really a great view of open, clean cords. One of the keys in any intubation is communicating with the other people around you. So what typically happens is folks that are learning to do intubations tend to be very focused on what they're doing, and they forget that there's a team around them that are there to help, and they do it in silence. And so I think some reassuring words to always hear from whomever is doing the laryngoscopy is to say things. For example, I see the vocal cords. You'd be surprised. I mean, lots of folks will just do silent intubations, and everyone else is left to wonder, what did they see? How did it go? So if you can say, I see the vocal cords, that's great. If you can say they are open, fantastic. If you're familiar with the grading scale and you can say, I had a grade 2 view or I had a grade 1 view, it just communicates to everyone else on the airway team that you understand the semantics, the vocabulary. It builds confidence in the team. Most importantly, perhaps, words and communication become critical when things don't go well. And so you don't want to be struggling with the descriptions of what I see when you can't secure the airway. You don't want to be searching for different words when the patient is desatting. Instead, you just want to be in the habit of saying, this is what I see, in whatever terms you might think. These are the 3 things I personally like to hear: is I see the vocal cords, they're open, I have a grade 1 view. And if you say I have a grade 4 view, or I can't see the cords, or the cords are closed, that can help me say, okay, well then I need to give different medications. I need to give more of some other medications. So I can help assist get the person intubating the best possible view and the best chance of success. So here's our second video. Go a little bit quicker in this. Let's see, pause there so you can see as we're coming down with the fiber optic camera, just to see the blade is already in place. Again, it's a MAC blade. You can already tell the tip is going to be just above the epiglottis, which is hanging down here. You can see a full view of the cords, so I would call this a grade 1 view. They are open. Here you'll see the arytenoids down beneath them. Some other structures here, you have the tonsils. You can see these are a bit bigger in this child, but nothing that severe. When they get really big, you can actually see them touching, and that's when you have to be worried about obstruction while the patient is breathing. Here as we drop down, again, just a great view of the vocal cords. You can almost see some tracheal rings down there beneath it. But here in this video, we're going to actually see a Miller blade being used. So you can see it's a straight blade here, but it's being used as a MAC. And all that means is that they're putting the tip of that straight blade in the vallecula. They are not using it to lift the epiglottis. And again, traditionally use a straight blade to lift that epiglottis. So let's take a closer look as you come in. Here you will see, here's a great example of the tongue being nicely swept all the way off to the side. So nothing there obstructing your view. From down here, you can already see the tip of the epiglottis here, and you can see that the Miller blade is sitting there in the valleculum. I can just start to see the base of the vocal cords down here, and I can see the arytenoids. Down here's the esophagus somewhere. That's just an air bubble, that dark spot right there. You don't want to put the tube obviously down there. You want to be able to lift that epiglottis, and then just underneath it, you're going to see those vocal cords. So we're going to get in a little bit closer, and you'll see, you'll be able to see where they're at. That's a good view. Over here on the left is a tonsil. You can't see the other tonsil on the other side. And again, not too bad at tonsils. That really helps your view. Come on in. Here you can see, again, some Great shot here of the tip of the Miller blade being in the vallecula, the epiglottis. This is what it normally looks like. It's being lifted up. You can see some arytenoids down here, and then right in here you'll see these vocal cords. Okay, here we're going to see a Mac blade actually being used as a Miller. So, all that means is that you have the Mac blade, obviously it's curved here, and that means that the tip of the blade of this Mac blade is actually being used to lift up the epiglottis. That's not traditionally how you use this blade, but there are no rules. You can use a Miller as a Mac, you can use a Mac as a Miller. Both blades can lift the epiglottis, both blades can be put in the valleculum. Let's go down there and I'll show you what I mean. I'll pause it right here. Here you have a great view of the uvula hanging down here. You see the tonsils. Again, not very big tonsils. They're not touching. It gives you a great exposure down to the cords. Over here you can see some tongue, just a little bit though. It's always better to get that out of the way. And then down here you're starting to see the base of the airway. So you see some arytenoids. I can already see the vocal cords. I don't see an epiglottis, and that's because the Mac blade is being used to lift that epiglottis. So let's take a closer look. And here's a better view of it. Here you can see the tip of that Mac blade. It's pushing up that epiglottis so that you have you have your vocal cords down here. So an excellent view. If you're doing a full fiber optic intubation, you just continue going down that hole with the camera. We're not going to do that here. We're just going to pull back so that you can get a nice view. You can easily see. Obviously no esophagus is easily visualized. You want to be looking for these white lines and that dark space right in between. It's easy to be tricked in some patients, but with good technique and your laryngoscopy skills, hopefully you'll find success. Thank you guys.